Hello, the purpose of this video is to give you, the nurse practitioner student, a model for presenting a case to your preceptor. As you begin seeing patients, your preceptor will expect you to perform histories and physicals, and then report your findings in an organized fashion. As you become more advanced, you will be expected to formulate a plan that may include diagnostics as well as treatments and follow-up. Let's go over the details of an HPI. We'll focus on a problem-focused visit rather than those for health maintenance. First, clearly delineate the reason for visit and state length of time. This can be a quote from the patient, such as, "I've had a headache for 2 days." Then utilize the acronym OLD-CART. The O is for onset. When did the pain begin? The L is for location. Where is the pain located? Does it radiate or is it localized? D is for duration. How long did the pain last? C is for character. How would you describe the pain? Have you experienced anything like it before? A is for aggravating factors. What makes the pain worse? Is it precipitated by activities such as after exercise? R is for relieving factors. What makes the pain better? T is for timing. Is the pain constant or intermittent? If it's intermittent, how often are you having it? Next, assess for associated symptoms. In our headache example, these might include dizziness, nausea, vomiting, photophobia, phonophobia. Take note of any pertinent negatives too. No relief from acetaminophen, no numbness, tingling, or unilateral weakness, for example. Go over pertinent aspects of the patient's medical history and medications. For instance, our patient with a headache may have a history of migraine. It would help us to know how his current headache compares with his usual migraine, as well as whether or not he's using his previously prescribed sumatriptan. As you have your conversation with your patient, you'll likely uncover details that are not related to the chief complaint. Unless these details require action, they can be omitted from your report to your preceptor. Be careful not to omit details that might affect care or patient safety. When performing your physical exam, you should focus on systems relevant to the problem. Your physical exam for a chief complaint of a headache should include heat or neurological systems. When presenting to your preceptor, make sure you include any positive findings on exam, as they'll need to be verified, as well as pertinent negatives in the relevant body systems. Finally, report any known results of diagnostic tests that are relevant, including lab results and scans. So let's summarize. First, chief complaint, including duration. Second, OLD-CART and associated symptoms. Then, positive findings on a review of systems that have not been previously addressed. Then, review medical history and medications, physical exam findings, and remember to report all positive findings. And finally, relevant diagnostic study results. Here are some tips for success. Never omit details that might affect patient care or patient safety. Remember to include pertinent negatives in both subjective and objective information. And don't report negative findings that are not relevant to the chief complaint. Now let's look at an example of a student, Sarah, presenting to her preceptor.
Hi Erin, I was wondering if you had time for me to present Mr. JK.
Yeah, absolutely.
Great. He's a 60-year-old man who presents urgently with new onset heart racing since this morning. When he arrived at his physical therapy appointment, his heart rate was found to be 130. He did state that he did not take his metoprolol this morning, so he left PT, went home, took his metoprolol, and reported to work. When he arrived at work, his heart rate was found to be 126. That's when he decided to leave work and present to the office. He reports slight headache and fatigue. He also states feeling overwhelmed with his recent health status, as well as a lot of stress at work. He denies any use of tobacco or recreational drugs. He does report 1 cup of coffee this morning. No complaints of chest pain, shortness of breath, fever, chills, no weakness, pain, or swelling. He also does not report any dizziness or loss of consciousness. Of note, his last EKG was March 2011 with no abnormal findings. Past medical history is significant for hyperthyroidism with a recent initiation of methimazole 8 days ago. He denies any heat or cold intolerance or weight change. and also denies a family history of cardiac disease or sudden death. Past medical history also includes hypertension, which is managed with metoprolol. He also has a history of diabetes mellitus, and he's on glucophage managed at the Joslin. History of depression 5 years ago following the death of his father. He reports not taking any medication at this time, but he does continue with counseling. His blood pressure today is 132/76. When I rechecked it in the office, it was 120/68, heart rate was 102. On exam, he's sitting comfortably, he looks well, no cyanosis, pallor, or diaphoresis noted. His skin is well perfused. Thyroid is 2 times enlarged. It's symmetrical without any nodules. As I mentioned before, heart rate is 102, and it's regular, no murmurs, rubs, or gallops, and his lung sounds are clear. Peripheral pulses are 2+, and his cap refill is immediate.
Okay, great. So what do you think we should do?
I think at this point we need to get an EKG.
All right, good place to start, but what else should we rule out?
Other causes of tachycardia include hyperthyroidism, which we already know he has, so we should probably draw a TSH.
Right. You're still missing one more condition that must be ruled out in order to get on with the tachycardia. You touched on it briefly in your physical exam when you talked about his skin being well perfused with no cyanosis or pallor.
Anemia.
Right.
So we also need to grab a CBC.
Very good. So what are your differentials?
Differentials include dysrhythmia, hyperthyroidism, and anemia.
Very good.
And I also think at this point, because he mentioned his stressful job, as well as feeling a little bit overwhelmed, we should consider stress and anxiety too.
Right. You're absolutely right. But before we can determine the cause of the patient's symptoms to be anxiety, we absolutely must rule out those other physical conditions. We can't afford to miss them. So let's go see this patient together, and then we'll go from there.
Perfect.
So let's summarize why this presentation was effective. Chief complaint included duration. It was concise, and it clearly identified the reason for a visit. History of present illness included all aspects of old cart and associated symptoms. Positive findings on review of systems were included. Pertinent medical history and medications were included. Physical exam was focused on systems pertinent to the chief complaint. Differential diagnoses were acknowledged, and relevant diagnostic studies were ordered to rule out the differential diagnoses. Thanks for watching. We hope this was helpful for you. Good luck in your clinical rotation.